Have you ever been in any one of these situations? You have a stable child who just needs fluids, but no laboratory tests. Or you've tried PO hydration, but it just keeps coming back up again, despite anti-emetics. Or you're repeatedly poking the stable but dehydrated child for what seems to be forever, without success. What now? One word, 3 parts. Hypodermoclysis, otherwise known as subcutaneous rehydration.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Clysis comes from the same Greek word that means a flood. So, hypodermoclysis refers to flooding the subcutaneous space with fluid so that it can be absorbed systemically. Sound far-fetched? Well, it turns out what is old is new again. In 1913, Dr. Day first described this technique for a child with severe diarrhea who couldn't tolerate fluids by mouth. Hypodermoclysis then began to gain popularity with a peak of use in the 1940s, until an innovative breakthrough in 1950. Dr. David Massa, a resident anesthesiologist at the Mayo Clinic, invented the first catheter-over-needle apparatus. With increasing safety and ready access of IV catheters, IV quickly overshadowed sub-Q. The subcutaneous route of hydration has also been used effectively in geriatric and palliative care for decades now, and it's only beginning to gain popularity again in its original population, children. So, how does it work? In a nutshell, you place a butterfly needle or angiocath into the subcutaneous space and you run fluids into it. The tissues quickly absorb the fluids, making them available systemically. That's it. Everything else we'll talk about today is just finesse. The ideal candidate for hypodermoclysis is the stable patient with mild to moderate dehydration who fails a trial of fluids by mouth or who needs a bridge to gaining IV access later, after a slow subcutaneous fluid bolus is given. Okay, so how do you do it? Let's talk about the best case scenario and we can work back from there. Emily is an 18-month-old girl who's had diarrhea running up and out her diaper all day today. Multiple family members have the same scourge. Mother is very conscientious and has been up all night trying to keep something in poor little Emily's stomach. Emily either pushes away fluids or soon vomits whatever her mother gives her. When Emily arrives with her mother, she's tired but not ill-appearing. Her heart rate is in the 130s to 140s, she has dry mucous membranes, and she's fussing at her mother and seems upset just to be held still in her mother's lap. With all of this crying, you'd expect more tears. So you try giving her an anti-emetic, fully aware that your chances of success are pretty slim. You're not surprised when her nurse flags you down to let you know this is a no-go. That's all right, we have a plan B. In fact, before you started your trial of PO, in anticipation, you placed a topical anesthetic cream on her back between her scapulae and covered it with an occlusive IV dressing. I like to use EMLA, or eutectic mixture of local anesthetics, but any topical anesthetic designed for intact skin will do. By the way, I know you've spent many a night wide awake wondering what eutectic means. Eu, EU, in Greek means good or correct, as in euthyroid, your thyroid's all right. Tiktos is melted, so eutectic mixture melts at just the right temperature, skin temperature, which allows it to be applied easily but absorbed readily when it melts to the right temperature and is absorbed into the epidermis and dermis. Okay, EMLA placed, and it takes at least 15 to 20 minutes to have some effect. Little Emily is on mom's lap, cuddling with her, leaving her back exposed, and more importantly, you're out of her line of sight. She's distracted by her mother singing to her. You wipe off the EMLA and clean the skin with alcohol or whatever your local protocol is for preparing an IV site. You can use either a 25-gauge butterfly needle or a 24-gauge angiocatheter. Keep it small. My preference is the angiocath because even though the butterfly will do no damage in the subcutaneous space, it tends to go over better with people you're trying to recruit to your cause. You gently pinch a fold in the skin and insert the needle or catheter at a 20 to 30 degree angle. If you have a butterfly needle set up, you can verify no aspiration of blood. If you're using the angiocatheter, you'll see any return if present. I mention this only if there's a question in your mind, but truthfully, I would be surprised if you somehow accidentally cannulated a tiny subcutaneous venule blindly. Now, here's the fun part. We can instill an enzyme that will create a temporary decoupling of the subcutaneous matrix to allow for more efficient fluid administration. What is that enzyme, you ask? Well, our subcutaneous fat and tissues are glued together with hyaluronic acid. So we can inject hyaluronidase locally for a temporary effect. Now, not to worry, we all replenish our hyaluronic acid every 24 hours and our matrix repairs itself within 48 to 72 hours. The typical dose for adults or children is 150 units of hyaluronidase injected subcutaneously. It starts working immediately, so there's no need to wait before you attach your tubing and start your therapy. Allen et al. In Pediatrics reported the results of the Infuse trial, which evaluated the efficacy, safety, and utility of using recombinant human hyaluronidase in children 2 months of age to 10 years of age with mild to moderate dehydration. Participants received 150 units of hyaluronidase, followed by an infusion of 20 milliliters per kilogram of an isotonic fluid over an hour. Rehydration was successful in 94% of patients, with high satisfaction scores for parents and clinicians. Best known practice is to use isotonic solutions, such as normal saline or lactated ringers as the initial fluid, although there is a lot of anecdotal experience with all IV solutions. After you've established the osmotic gradient and gotten some fluid volume into the child, it's fine to switch over to solutions containing dextrose, like D5NS, which is a great way to break the ketosis in vomiting children to get them less nauseated. You can also use more dilute solutions or those containing electrolytes for subsequent doses, but for me, I typically stick to isotonic solutions when I perform hypodermoclysis. There's no need to get complicated. You can set the line to gravity, and if it's dripping in, you may just leave it be. But if you see a very slow drip by gravity, or worse, nothing is dripping, you can set the line on a pump to deliver up to 20 mL per kilo over an hour. Infusion at this rate optimizes the balance we want in minimal discomfort while maximizing the flow rate. So you can see this is not a bolus in the true sense. But then when you compare it to the alternative, like IV therapy, we can see a time and cost savings. Dr. Mace and colleagues in the American Journal of Emergency Medicine report substantially decreased cost and ED length of stay when comparing the material and human resources needed to place an IV in a squirmy young child, compared with a simple, subcutaneous stick by stealth. Noah is a 6-year-old boy with autism and developmental delay who's had a viral syndrome and terrible herp angina. It's really difficult to get him to take anything by mouth. It just plain hurts to eat or drink. Even trying to get an analgesic in him to help him with his pain is a battle. Somehow, your awesome colleague ahead of you got an IV in this very upset young man. The sign out is, finish his fluid therapy and he'll be all right to go home. Do you ever get the feeling that the medical gremlins who hide from you during your shift somehow come out to play just when you're signing out to your colleague? As you're getting the story, Noah's nurse announces that Noah promptly pulled his line. Oh boy. Apparently, it took a lot of cajoling to get the line in the first time, and his parents are understandably leery of another poke. Noah is another perfect candidate for hypodermoclysis. Another added benefit to using the back is, again, out of sight and hopefully out of mind with a topical anesthetic, but also we just have less nerve endings on our backs in comparison to, for example, our hands or forearms. When you think about it, EMLA will take care of that lancinating pain that the needle gives you as it goes through the dermis. It's one and done. During formal venipuncture, the skin is penetrated, often in a sensitive area, and then the perivascular nerve endings are disrupted by the needle. Add to that the fear and sense of helplessness some children feel when we gang up on them and hold them down. It all adds up to what can be a traumatic experience. So, Noah has his EMLA, he is distracted with a smartphone, and you're able to place a 24-gauge angiocatheter between his scapulae. Really, you can place the catheter subcutaneously anywhere you can pinch an inch. Now, Noah will not likely put up with a lot of hassle during this procedure, so whatever you can do to minimize his annoyance will maximize our success in rehydrating him. Here's a nice tip in securing the subcutaneous infusion line. Okay, there will be swelling. That's the goal. It's really painless, and if Noah wants to lie down on his back with the pump going, that's just fine. It's actually pretty comfortable for most children and adults to do. Now here's the tip. Since there will be swelling, we want to be careful about how we secure the line, so how you tape it down to the skin is important. We want to avoid that pulling sensation you can get, which can be the beginning of the end of the tolerance for the procedure. So imagine the catheter already in the skin. Cover that with an occlusive dressing like you would any IV site. The footprint of the occlusive dressing is relatively small, so it will travel up on top of the subcutaneous mound you're creating. As the IV tubing exits the occlusive patch, place a thin layer of gauze between the skin and the IV tubing so that the tubing doesn't press into the skin. Then, as far away from the puncture site as possible, tape it down securely. The idea is not to tape it down on the growing mound itself, because the mound may pull at the anchored skin and set a nuclear chain reaction of annoyance and restlessness, and we've all seen the final result of that scenario. Now, the site will look indurated, a pinkish red, almost like you just caused an abscess. It's not an abscess. It's not an allergic reaction. Even with the old preparations of hyaluronidase, allergic reactions were rare, and now they're very rare with the recombinant preparation. It's supposed to swell and look kind of ugly, but temporarily. The subcutaneous tissues will swell to a point where you have a steady state fluid administration rate, and as soon as you stop the infusion, the remaining fluid will start to subside as it is absorbed. You finish Noah's infusion and he tolerates it well. You could even add some ketorolac to the subcutaneous infusion to help him with his pain. Currently, that's off-label use, but numerous studies have shown the safety and efficacy of ketorolac via the subcutaneous route, most recently in a literature review. Just food for thought. Mikey is a 12-year-old boy with intellectual disability and cerebral palsy who has very limited expressive language. He's bedbound and dependent on a gastrojejunostomy tube. Well, unfortunately, the tube was dislodged today. Mikey probably pulled it out, and now he's pretty uncomfortable. Now, as you know, it takes some force to get that well-placed GJ tube pulled. You delve a little further. Mikey's been a bit more restless over the past few days with a tactile fever. What could have caused him to become more upset and pull his tube? You listen to his chest and confirm your suspicion. Right lower lobe pneumonia. His clinical picture looks like he probably wouldn't do very well as an outpatient. He's hemodynamically stable but moderately dehydrated. He needs fluids and medications. You can place a Foley catheter to keep his stoma open, and of course you can give him some medications this way, but he's gonna need more fluid therapy, and Mikey is a notoriously difficult IV stick. He's not so sick that he needs an intraosseous line, so why not start with Hypodermoclysis as a bridge to IV therapy? Kunsting et al. In the Journal of Emergency Nursing in 2013 compared subcutaneous fluid infusion with intravenous fluid infusion in children with difficult IV access. They found that the mean time from order entry to subcutaneous fluid infusion to be 20 minutes, compared to the failed IV access group with an average infusion start time of 1.5 hours. The latter group eventually got subcutaneous fluids. The message here, I think, is that sometimes we don't realize when we're fixated on getting an IV that we're taking a long time to get it and we're poking that child quite a bit. In this study, the investigators also found a shorter length of stay in the subcutaneous group. They further commented on a subgroup who received subcutaneous fluids initially and later in IV. They found a trend in ease of IV access after subcutaneous fluid therapy. In other words, if your little patient with difficult IV access is hemodynamically stable and amenable to a bolus over an hour, you may choose to start with subcutaneous rehydration and reevaluate. Much has been studied and written about the predictors of difficult IV access in children. The most often cited are age less than 3 years, weight less than 5 kilograms, prematurity, obesity, and darker skin tones where the contrast of vein to skin may not be so apparent. There's even a validated score for difficult IV access. The 3 main predictors of the score validated by Riker et al. In Annals of Emergency Medicine include the most practical and universal of features: vein palpability, vein visibility, and patient age. If you're anticipating difficult IV access in the child who can stand to wait an hour or so for a slow bolus via the subcutaneous route, you could start with subQ to get those veins plumper and more visible to improve your chances of IV access in the very near future. Now remember, you can administer hyaluronidase and fluids subcutaneously anywhere you can pinch an inch. This includes the back, anterior and posterior arms, bilateral chest, abdomen, and anterior thighs. Personally, I think the arms can be a little problematic because if there's circumferential swelling, we can upset everyone who will later care for the child if this is somehow confused with some venous stasis issue. I like to steer clear of the extremities if I can. A very popular site in the elderly is the abdomen. The elder can go about his or her business, often reclining comfortably in a chair, reading, visiting, eating, or watching television, all while hypodermoclysis does its rehydration magic. For Mikey, it may be a bother for him to deal with the setup on his back. You could get him to lie on his side to start, and then he could lie on his back as the infusion proceeds. But he does seem less agitated now that you've given him an antipyretic through his stoma via the Foley catheter, and he is used to having something on his abdomen. We can perform hypodermoclysis on either side of his umbilicus. Mikey tolerates a 20 ml per kilo bolus of normal saline subcutaneously on his abdomen, and now his usual venipuncture site is palpable. You establish IV access and continue your treatment. If you were stuck with only subcutaneous access, you could give medications via the subcutaneous route, like most third-generation cephalosporins, sedatives such as midazolam, or analgesics such as morphine or fentanyl, to name a few. Now, not all are compatible with each other, so if you go this route, be sure to look them up. I have a table for you in the show notes. I mentioned the possibility of giving medications in conjunction with hypodermoclysis because there are a few times when it may come in handy. But for me personally, and honestly, I would say that many times we can give these medications PO or via G-tube safely with good bioavailability, and we don't have to worry about the subcutaneous or IV route. If we really need an IV and we don't have it, then we always have IO. In other words, yes, some medications can be given via the subcutaneous route. Just be careful with mission creep here. If you can give via traditional means, it's probably a better bet because most drugs have been studied more IV. And always just ask yourself, in the child without vascular access, do I need an IV? If no, then keep going with the subcutaneous route. If the answer is yes, I need intravascular access, and I can't get it now, then IO is always a nice backup. Okay, let's do a little troubleshooting. What about catheter size, and what if you don't have hyaluronidase? First, catheter size. You don't need to use larger needles or angiocatheters for older children, adolescents, or adults. A 25 gauge butterfly or 24 gauge angiocatheter works well from an infant to an elder. In one study of adults by Thomas et al. In the Journal of Palliative Medicine, a half a liter of saline was infused by gravity via a 24 gauge catheter. Now, this goes against our traditional reflex knowledge that when we talk about IV access, the shorter and larger the bore, the faster the infusion. In subcutaneous infusion, it's not the size of the catheter that determines absorption, but the osmotic gradient. A larger catheter gets there no faster because it's up to the tissues to obtain a steady state of absorption. There's just no extra gain to a large gauge. You can use up to a 21 gauge butterfly needle or a 20 gauge angiocath in adults, but why bother? You'll have more pain and no more gain than with a small needle or angiocath. Now, what if you don't have that fancy hyaluronidase? Next chance you get, ask your friendly neighborhood hospital pharmacist. It's actually increasingly readily found and available in generic form. If you have it, please use it. It will make a believer out of you and others. Now, it's okay not to use if you don't have it available to you. The process of subcutaneous rehydration just takes a lot longer to work, but it'll work. In a double-blind crossover trial, Thomas et al. In 2007 compared subcutaneous administration of lactated ringer solution by gravity with and without hyaluronidase. The hyaluronidase group received their fluids 5 times faster. The average rate of the hyaluronidase group was 382 milliliters per hour versus the fluid-only group who did not receive hyaluronidase. They were substantially lower at 82 milliliters per hour. So you can see it's worth using if you have it, but still potentially useful if you don't. Okay, a quick case I want to share with you. This was a recent case of a 2-year-old girl with a respiratory virus that turned her into a hot little firecracker. She was very upset and refusing to drink. Really, she was otherwise well, maybe mildly dehydrated, but very symptomatic. She pushed away everything we gave her. So I thought, let's try Hypodermoclysis to perk her up while we get her more comfortable. And of course, it just so happened that we were late in getting a shipment of hyaluronidase to our pharmacy. I talked to Mom, let her know the plan, that it would take a little longer than usual without the medicine, and although Mom was skeptical at first, we got Little Miss Firecracker to extinguish her fussiness. A slow, small mound formed, and she got maybe 100 or 125 mLs in, so about half a bolus for her. She defervesced, she felt much better, and she started taking her frozen Pediapop oral rehydration like a champ. So, without hyaluronidase, hypodermoclysis is possible, just slow. And in some situations, that may be just fine. Use it if you got it. So, to recap the supplies you'll need. First, EMLA or any topical anesthetic used for intact skin, placed as soon as possible as the decision is made. 2. A 25 gauge butterfly needle or 24 gauge angiocath. 3. IV tubing. 4. 150 units of hyaluronidase, the same dose regardless of age or size. 5. Isotonic fluids. You can start with 20 mLs per kilo. And finally, a well-informed team made up by the patient, the parents, and your staff so that everyone knows what to expect for a successful subcutaneous fluid administration. Thank you for listening. Now go out there and advocate for an oldie but goodie. Hypodermoclysis, subcutaneous rehydration, early and often. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.